I'd like to welcome you to this webinar from the Council of State Governments. I'm a professor and associate dean and co-director of the Brooklyn Initiative to Develop Geriatrics Education at SUNY Downstate Health Sciences University. But my real role today is as a health policy consultant to the Council of State Governments East. Our webinar is a joint presentation of CSG East Education and Workforce Development Committee and the Health Policy Committee, partnering with the State Exchange on Employment and Disability. So it's really clear that this is an important topic that we're going to talk about today, addressing the mental health needs of workers. There never could be a more critical time. As we know, COVID-19 has a significant impact on what has happened to the workplace, and the issues of mental health and the workers' needs in the workplace are even greater. As we get underway this afternoon, we want to welcome Senator Gustavo Rivera, who will be saying a few words, and welcoming you as well to this. He chairs the Committee on Health Policy in the state of New York and leads the CSG Health Policy Committee. Senator Rivera has represented the 33rd Senate District in the Bronx, very proudly I might add, since 2010. Thanks, Senator Rivera, for joining us.
Thank you so much, Shirley. And again, my name is Gustavo Rivera, State Senator for the 33rd District in the Boogie Down Bronx. Yes, I have various masks to prove it. There's that one, and there's that one, just so that people don't forget. And I also would, so I'd like to thank all of you for being here. And I want to welcome you to this webinar that on addressing mental health needs for workers, hosted by CSG. As was mentioned, I'm the chair of the Health Committee here in the Senate. I'm also the chair of the Policy Committee for the Health Policy Committee for CSG East, and I'm very proud to be here in that capacity this afternoon. Now, May is, as we're probably all aware of, is Mental Health Awareness Month, but in many ways, we have never been more aware of the mental health challenges that Americans face on a daily basis. The fact is that over the last 2 years, the COVID-19 pandemic, as it has done for so much else, has not only demonstrated the gaps that exist in so many of our systems and certainly our health system, and has actually exacerbated what is already a behavioral health crisis in this country. And but it has prompted many others to seek help, right? And so now we have COVID protocols all across the states that are lifted in so many places, and many Americans are returning to the workplace on a more regular basis. In fact is that they may find actually employers that are more cognizant of the mental health needs of workers all over the country. But there's also the challenges that creates, because we have to navigate a workplace culture and the cultural stigma that we recognize still exists, that around mental health issues generally, and certainly around the idea of seeking help. So what we're going to do today is we're going to hear from state policymakers from around the country that can support and who are supporting in their work every day. There were both employers and employees advancing access to mental health services and supports, addressing behavioral health workforce shortages, and helping to shape a more compassionate American workplace. Now, you hear from a great lineup of speakers, including academics, practitioners, and my colleagues, policy makers, as well as policy analysts from all over the country. And I want to thank you all for participating. And so to get our program underway, I want to welcome Sean Sloan from the Council of State Governments. So thank you all for being here. And over to you, Sean.
Thank you so much, Senator. I'm Sean Sloan. I'm a senior policy analyst and a 15-year veteran of policy work at CSG. Last year, I led a project on mental health policy supported by the Commonwealth Fund that produced a mental health resource guide for state policymakers. Here is a look at today's agenda. Andrew, if you want to move on to that agenda slide for us. One programming note, we received late word this morning that New York Assemblywoman Aileen Gunther isn't able to join us, but her legislative director, Thomas Gatto, has agreed to step in for her and can speak to the particulars of the legislation that the Assemblywoman had introduced. Also, one housekeeping note as we move into our presentations, if you have questions for any of our presenters this afternoon, you may type them into the chat at any time, and we will ask as many questions as time allows at the end of today's webinar. First, we want to introduce you to the concepts behind state mental health policy. And here to help us do that is someone who has become a great friend to CSG. Robert Bobby Silverstein is a disability attorney at Powers Law in Washington, D.C. He is legislative and policy counsel for the State Exchange on Employment and Disability, of which CSG is a partner. His many career accomplishments include serving as staff director and chief counsel for a U.S. Senate subcommittee on disability policy, where he became known as the behind-the-scenes architect of the Americans with Disabilities Act. Bobby, thank you so much for joining us.
Thank you for the opportunity. Again, I am part of the SEED team, and Elise, who's going to be chatting with you right after I am, will tell you a little bit more about the SEED project. But we are going to pull together policymakers and experts meeting Monday on a mental health collaborative to look at the issue of mental health in the workplace. And in preparation for that collaborative, we surveyed state policymakers and experts and came up with 5 basic themes for looking at this issue of mental health in the workplace. The first theme is enhancing non-discrimination, parity, and benefit policies. You have in many states state equivalents of the Americans with Disabilities Act. What do they say in terms of mental health issues? We have mental health parity legislation at the federal level and the state level. And we see that there are a number of entities who are tracking this policy and identifying best practices. When we look at this issue, we have to look at workers' compensation and long-term and short-term disability insurance as another subtopic to address. Historically, workers' comp has not covered mental health issues, but there has been a trend at the state level towards covering. Then we have paid sick leave, family leave. And then there are issues about self-disclosure of disability, and do employers, can they or take adverse action for those who are in rehabilitation programs? And some of you may be aware of the fact that the Civil Rights Division and the Equal Employment Opportunity Commission just recently, within the last couple of weeks, have a policy brief calling the ADA and the opioid crisis, combating discrimination against people in treatment and recovery. The second basic topic that we've identified for state policy is workplace care and supports and reducing social stigma. So we've looked at best practices on reasonable accommodation, telemental health policies, wellness programs, employee assistance programs, drug-free workplace, including diversion programs. A third topic we're looking at for the collaborative is behavioral health crisis service systems, with the 911 program coming on board in July. We're examining the National Suicide Hotline Designation Act and model bills that states have developed given the flexibility in the federal legislation. A fourth topic is underserved rural areas, as well as underserved racial and ethnic communities. And we have, again, surveying state legislation, see that states are establishing agencies, task forces, advisory councils. Some have equity impact statements requiring equity state plans, data collection, culturally tailored competent training, behavioral health diversion programs, and again, in broadband, in rural areas, broadband and telemental health topics. So these are all the issues that we're looking at, and states have developed policies on with respect to underserved populations. And the fifth broad topic area is workforce shortages, the reasons why and what states are doing about it, as well as states that are developing resource centers and changing licensure requirements in terms of the shortages, developing action plans, continuing education programs, and the like. And so in a kind of overview, quick 5-minute, these are some of the topics that your colleagues around the country are developing, and the SEED project on Monday is going to have a collaborative talking about all these issues, and ultimately there'll be a task force and then a report by CSG, NCSL, National Governors Association, and other partners in the SEED project. I'm going to turn it over to Elise now.
Fantastic. Thank you so much, Bobby. Andrew, we can advance to the next slide. My name is Elise Gurney, and I'm a senior policy analyst with the Council of State Governments. And today I'll be talking about addressing the mental health needs of workers throughout and beyond the COVID-19 pandemic. We can go to the next slide. The information I'll be sharing today was developed in our capacity as members of the State Exchange on Employment and Disability, which Bobby had mentioned before. This is an initiative of the U.S. Department of Labor's Office of Disability Employment Policy, otherwise known as ODEP. And the focus of SEED is to help state and local governments develop and implement policies and practices that lead to increased employment opportunities for people with disabilities. And something we will talk about in a moment is how mental health conditions can qualify as disabilities, which is why this topic falls within the scope of SEED's work. SEED does this work in a variety of ways, including providing policy assistance and technical assistance. So that could be everything from doing research on specific policy areas to drafting legislation to convening policymakers to share and circulate best practices. If you would like to find out more about SEED, Dina has just put a link into the chat. Thank you. And you can find out more that way, but please don't hesitate to reach out to us and we can assist in any way that we are able. Next slide, please. So I very likely don't have to tell you all that the COVID-19 pandemic and corresponding economic recession has had significant impacts on people's mental health. This is a result of everything from increased isolation, loss of social support, changes in household dynamics, and financial and job security concerns. And this has had implication for workers in two distinct ways. One is that employees with pre-existing mental health conditions may be experiencing an increase in symptoms. According to the Equal Employment Opportunity Commission, individuals with pre-existing mental health conditions may have more difficulty handling disruptions to daily life that have accompanied the pandemic. So that's the first implication. The second is that more workers are struggling with mental health conditions than prior to the pandemic. So in 2019, before the pandemic started, 1 in 10 adults reported symptoms of anxiety or depressive disorder, and that has increased to at least 4 in 10 adults during the pandemic. Next slide, please. And this can have some significant impacts on a person's ability to find and maintain employment. Mental health conditions can interfere with essential workplace skills, everything from participating effectively in teams to interacting with customers and coworkers to maintaining concentration. And it's important to note that we're not just talking about serious mental illness, we are also talking about moderate mental illness that can also have employment impacts. 75.9% of people without a mental illness are employed, compared to 62.7% of people with a moderate mental illness. That's about a 13 percentage point difference. Next slide, please. It's important to evaluate what existing supports are in place to help workers handle their mental health conditions and meet their mental health needs. Mental health conditions, as I had noted before, can qualify as a disability if they substantially limit one or more life activities, and that can include employment. So if someone's mental health condition does meet those criteria, they are entitled to reasonable accommodations in the workplace under the Americans with Disabilities Act. Reasonable accommodations are adjustments to a work setting that make it possible for employees to perform essential functions of their job. And when we're talking about mental health, this can include things like allowing a worker to work remotely in order to manage their mental health needs, to take more frequent breaks, as well as to take leave for reasons related to managing their mental health conditions. So again, these reasonable accommodations are mandated, but we find that they're not sufficient in addressing the full scope of mental health needs that workers have. Employees indicate that they feel they lack workplace supports for managing their mental health conditions. So fewer than 50% of workers think that their employer provides a safe and welcoming environment for employees with mental health conditions. And there's some additional statistics indicating that people also don't know where to go to access workplace mental health supports. So workers don't necessarily feel supported in the workplace. And in addition, they encounter barriers when they try to access external supports related to mental health. Only half of people with mental health conditions receive treatment, and the barriers to this can be numerous. High cost, for example, insufficient insurance coverage, limited options and long waits, especially in areas that have provider shortages. And I know Bobby had mentioned rural areas as being potentially one of those. Lack of awareness of where to go for services, and perceived social stigma when it comes to receiving services. Next slide. So in the remainder of my time today, I'm going to be talking about some findings from a brief that SEED published last year called Addressing the Mental Health Needs of Workers Throughout and Beyond the COVID-19 Pandemic, State Responses. So it provides strategies for how states can support worker mental health. It provides a number of state examples and details that complement the findings Bobby had shared earlier. I'll just be providing a higher level overview right now, but we will put the link in the chat for you to access the full brief. And again, we encourage you to reach out with any additional questions. Next slide, please. The three strategies we'll talk about are increasing access to telemental health services, strengthening supports for heavily impacted communities, and expanding workplace mental health supports. Next slide. So first, we're talking about increasing access to telemental health. We've seen that telehealth has been a key way that individuals have been able to access mental health services during the pandemic. According to the insurance company Cigna, more than 60% of behavioral health customers use virtual services during the pandemic. And during initial stay-at-home orders, so that would be March to May of 2020, 97% of people who access behavioral health services remotely did not have a prior telehealth claim for behavioral health. So a lot of people accessing telehealth services for the first time. So some of the specific strategies around expanding access include requiring Medicaid plans and/or private insurance to cover telemental health services. There are 33 states that require Medicaid plans to cover telemental health services, and 21 states that require private insurers to do the same. Another strategy is increasing mediums, platforms, and settings for telehealth, so allowing people to access it through a variety of different platforms, as well as accessing it asynchronously, meaning that a provider and the patient are not necessarily in this accessing and communicating at the same time. Another strategy is expanding the types of providers who can provide telemental health services, whether that be out-of-state mental health providers or additional types such as psychiatric mental health nurses. And then finally, providing technical assistance to mental health providers around telehealth to help provide them the supports to effectively offer and provide telehealth services. Next slide. I will highlight two state examples, but again, the brief is full of additional examples as well as additional strategies around expanding telehealth access. But in Louisiana, House Bill 449 expands the types of healthcare providers who can perform telepsychiatric evaluations, and that includes those psychiatric mental health nurses I had mentioned before. In Rhode Island, the Department of Behavioral Healthcare, Developmental Disabilities, and Hospitals leveraged resources from the Northeast Telehealth Resource Center, and they provided twice-weekly technical assistance webinars for behavioral health organizations surrounding telehealth best practices. So again, relating to the point of supporting telehealth providers in providing telemental health services effectively. Next slide. Second main strategy is around strengthening supports for key communities. I know our previous speakers touched on this, but we know that the COVID-19 pandemic has disproportionately impacted certain communities. And the two that we focus on here are minority communities as well as essential workers. So those impacts have been disproportionate in terms of the incidence rate of COVID, as well as the death toll and mental health impacts. Essential workers were more than twice as likely to have been diagnosed with a mental health disorder since the pandemic started compared to people who are not essential workers. In addition, Hispanic adults reported a higher prevalence of psychosocial stress related to not having enough food or stable housing during the pandemic compared to adults in other racial groups. And on the right, we have an image of a man driving a bus wearing a mask, and this is meant to illustrate one type of essential worker that we're discussing here. So a few approaches to addressing the needs of those communities include convening task forces and advisory councils to identify and address the mental health needs of minority groups, increasing availability of and access to culturally competent mental health care. This is really key. It's not enough to simply make general mental health care available, but to ensure that it is recognizing and addressing the cultural context in which a person lives. If this is not done, it can risk re-traumatizing an individual who's experienced trauma either as a result of the pandemic or in another context, and it can also be less effective. And then the third strategy is establishing mental health hotlines and other supports for essential workers who have been impacted by the pandemic. Next slide, please. So some examples here, Ohio had convened a COVID-19 minority health strike force, and that focused not just on mental health, but a variety of other health issues as well. But it had made recommendations for increasing access to mental health services for communities of color. So this addresses that task force point, which is a great starting point for thinking through some of these issues and necessary supports. In New Jersey, Senate Bill 2447 proposed establishing a helpline for first responders and healthcare workers experiencing pandemic-related mental health issues. Next slide, please. And the final strategy I'll talk about is expanding workplace mental health supports. Something we talk a lot about with SEED is the idea of state as a model employer. So in a lot of states, states are the largest employer. And so when they make changes to either their hiring practices or their workplace policies and programs, they can impact a lot of people's lives. And states also have the capacity to create incentives and supports and other programs to help encourage certain behaviors from the private sector. And I'll talk about strategies for both of these right now. So our strategy is requiring employers to provide sick leave, and then in addition, allowing employees to use it for managing their mental health needs explicitly. Providing resources and technical assistance to guide organizations in developing mental health supports for their employees. This would be the corollary to what we talked about specifically related to telemental health, but again, more related to implementing programs such as workplace wellness programs and employee assistance programs. Third strategy is training state employees on supporting mental health in the workplace. One example of this is offering what's called mental health first aid at work. And this helps equip people to understand what the signs are when someone is experiencing a mental health crisis and how to connect them to appropriate supports either within an organization or beyond. So again, one example of the type of training that could be provided. The final strategy I'll mention is expanding those mental health supports I talked about before, so workplace wellness programs and employee assistance programs for state employees, as well as encouraging through tax incentives or other strategies, encouraging private sector employers to offer those same types of programs. Next slide. So what I will leave you with is two examples here illustrating these strategies. One is from New Mexico. House Bill 20 allows employees to use sick leave for managing mental health illness, injury, or health conditions. So that's in addition to just physical illness, injury, or health conditions. And then in Wisconsin, Senate Bill 73 creates an income tax credit for workplace wellness programs, and that can include stress management. So a very good example of creating incentives for the private sector to implement some of these support programs. So that concludes my portion of the presentation. I will turn it over to Sean. Dina has really helpfully been including some resources in the chat. I encourage you to look at those, and we will have time for questions at the end of this session. Thank you so much.
Elise, thank you so much, and thanks to Bobby as well. So now we are going to hear about just how much employers are recognizing the importance of helping workers to seek care to address their mental health needs. Matthew Ray joins us. He is Associate Director for the program on the healthcare marketplace at the Kaiser Family Foundation in Washington. In November, KFF released the 2021 Employer Health Benefits Survey, which, among other things, examined recent changes to mental and behavioral health benefits due to COVID-19. Matthew, thank you so much for joining us.
I'm thrilled to be here. At least that was great, and it perfectly dovetails with what I'm going to talk about. So we couldn't have planned this any better. So my name is Matthew Ray. I'm Associate Director at the Kaiser Family Foundation. We're a nonpartisan, nonprofit research institute. We do examine the healthcare system and how it's working for everyday people. So more and more of our focus has been on mental health in the last couple of years, especially in the last year for obvious reasons. So we're doing more and more work on mental health, and I'm going to highlight some of the sort of big findings we have. Next slide. So as Elise said, this is unparalleled indicators of people indicating that they have mental health conditions or self-diagnosing with mental health conditions on household surveys. So the National Health Institute survey found about one in 10 people with a mental health, anxiety, or depression disorder in 2019 compared to about 4 in 10 in 2021. And this is absolutely reflected in all of the meetings I do with employers. I talk to employers as often as I can, and I would say it's the #1 topic is what they can be doing to support the mental health care needs of their employees. Very much so. Next slide. So in our employer survey, we just get on the phone and call employers and then ask them what they're thinking. So this was from last year. One of the questions we asked if they had seen a change in their mental health care utilization in the prior year because of the pandemic. And obviously 4 in 10 of the largest employers indicated they had. And I think among the smaller employers, they tend to follow their utilization less. I think that may mask how much need there is even amongst smaller employers in addressing mental health needs. Also not to be forgotten is as we deal with the COVID-19 pandemic, we're still very much in the opioid pandemic. So 7% of large employers said during the course of the pandemic, they saw an increase in their substance abuse utilization as well. So this reflects the pulse data that there's just unprecedented need at this moment. Next slide. It's just really, at least at this point too, it's just really important to remember that even prior to the pandemic, we were not where we should have been on delivering services to people with mental health care needs. So this was looking at the National Health Interview Survey, where we figured out about a third of people who have symptoms of severe anxiety or depression were not receiving treatment prior to the pandemic. There's no reason to think those numbers have gotten any better over the last 2 years. We're obviously going to keep tracking that, but with increased need, I think our system has been extraordinarily strained in making sure that we have the workforce to meet the mental health care needs of the population. Next slide. So this is back to our employer survey. So the big thing we did here is we just asked employers what they did. Obviously, as I said, employers were very focused on that mental health needs, and I think are still very focused. So when I look at this, the big things at the bottom here that lots of employers were doing was expanding their EAPs and also developing new services, new online apps, new digital resources to help employees and their dependents manage stressful situations and the like. And that's great. On the bottom of this, sort of the things with the smaller percentages there are things that are more changes to benefit design and the coverage. So we have 4% waived cost sharing for mental health and substance abuse services, and 3% increased coverage for out-of-network mental health and substance abuse services. Those would be the cost elements, under cost and access, let's say. So I think lots of employers that I talk to are thinking about digital apps and the like to get that service. It's around the coverage bits that are harder. And that's what I want to get to next. Next slide. So, provider networks for mental health care services are much narrower than they are for general healthcare services, and for those on employer coverage and for those on in the healthcare marketplaces, the so-called Affordable Care Act exchanges. So we get about 70% of large employers telling us that they have a broad network, a very broad network for their provider network. When we ask them if they're specifically about mental health care services, it's only about 33%, actually 37%. So significantly smaller percentage of firms indicate they have broad networks here. Next slide. And that kind of gets to one of the points that Elise really highlighted here. One of the ways that I think employers were filling the gap over the last year was through telehealth. And this orange line jutting up into space here is the share of outpatient office visits by a large group enrollees that took place through telehealth. So you see at the peak of the pandemic, let's say, at the peak of the shutdowns, the peak of the pandemic is a sort of an ongoing target. About 40% of outpatient office visits were delivered via telehealth. And there's been not that much decline. We're still well up over 35%. Compare that to all other services. We peaked at about what, 12% or so, and about half of what it was. So where lots of services went online for mental health care services and have stayed online, lots of other services have gone back. I think employers were thinking about adding these parts to their health benefits. Now, telehealth, for all the reasons Elise just laid out, is very much a moving target with employers and how they're thinking about it. Worries about cost, excess utilization, access barriers, whether how this integrates into their other value-based design programs are all very complicated, and it's very much remains to be seen what employers do going forward. But invariably, mental health is going to be delivering mental health care services is a bigger deal in telehealth. And that's something we're going to ask a lot of questions about in our 2022 Employer Health Benefits Survey sometime this year. And then my next slide. And this is just, just to get to this issue of networks, and which I think is really where workers get stuck with cost, is when you go out of network. And given how small some provider networks are, it's easy to do. So the question is, why don't we just have more broader provider networks for health services? It's hard because we don't necessarily have the workforce in all the places we need to access the services, and there are other constraints. One thing that to look at is this is the percentage of physicians who take new patients with a particular payment type. So virtually, we're up over 99%, 90% for all the specialties other than psychiatry. So 60% in the greenish color there, 60% of psychiatrists take new patients paying with private health insurance. It's indicative of low payment rates. It's indicative of not having enough psychiatrists. But that is one of the challenges employers have, is trying to figure out building networks, employers and their insurers and TPAs, building networks that have got psychiatrists, enough psychiatrists in them. So that's the push I wanted to hit. I think a lot of that complemented what Elise said, and happy to share any of these resources. We've got lots of stuff coming out of mental health that I hope is useful to everyone. I think it was like 10 minutes too, but I didn't go over it, I don't think.
Perfect. Thank you so much, both for keeping to the schedule, but providing us with some wonderful information. Matthew, we know now from what we've heard even so far and from our own experiences, how incredibly complex the issue is. And it's more than just public policy. It's more than just what goes on in the workplace. There's a lot of issues that are getting raised, and we have some exciting questions that are popping up that are raising our consciousness even further in the chat that we'll get to later. But one of the things in terms of the culture in the workplace, and that has been alluded to earlier, and our next presenter is going to talk about some of these issues in relation to employment. Mark Abelard, thank you, Mark, for joining us today. And he is the Director of Strategic Partnerships and Director of the Behavioral Health Service Course at William James College's Center for Workforce Development. In addition, and the way that I got to know Mark was through contacts at the Heller School at Brandeis University, where he's pursuing his doctorate and doing research in racial and ethnic disparities in the mental health field, as well as the impact of innovative programs to diversify the mental health workforce. He's a combat veteran with a distinguished Marine Corps tenure in the Persian Gulf, so certainly knows a lot about stress, I'm sure, that he can share with us. Thank you so much, Mark, for being with us.
Thank you, Shirley. what we know is that although that Massachusetts is amongst the best resource states in the country, we still face significant challenges when it comes to access to care. A recent study from Blue Cross Blue Shield Foundation found that there was 5 core values that they wanted to present to make it easier for folks to find care in Massachusetts. One was to ensure that the availability of comprehensive person-centered care for behavioral health continued across the continuum. Invest in the workforce development and capacity efforts to attract and retain behavioral health professionals, and provide the support of the development of a culturally competent and diverse workforce. 81 million Americans currently, that's 81%, I stand corrected, that's 43 million American adults have a mental illness. 9.8 million does suffer from a seriously debilitating mental health disorder, and 20 million adults have a substance use disorder. We know that 17 million children in adolescents have a mental illness, and that was before COVID. And we also know that untreated mental health illness costs the nation about $300 billion annually. That's $300 billion annually due to loss of productivity in the workforce. We know that the behavioral health force is essential support for the health and well-being of underserved populations in Massachusetts. And with the help of Michael Weeks Providers Council, we held focus groups with about 100 member organizations or so. And we spoke to their CEOs, their senior HR folks, their directors, their clinical supervisors, and most importantly, their entry-level workers. And what we learned is that there was 2 primary issues when the employees were facing when they tried to access career ladder advantages, and that was time and money. They didn't have the time to pursue educational attainment due to working multiple jobs. And quite frankly, they didn't have the money, they couldn't afford the cost of education. And we know that the employees are struggling. Out of those focus groups, we learned that there were some employees with as high as 700 vacancies in their organizations. That's 700. And exacerbating that, we found that up to 40% of their new hires did not stay in the workforce. So they had a severe retention issue when it came to the hiring and the retention of the folks that they were bringing into the workforce. And coupled with that, we found that the difficulty in attracting and retaining talent primarily was attributed to the low pay of the field. Entry-level workers in behavioral health do not make a livable wage, especially when you live in a state like Massachusetts with the high cost of rent and a high cost of living. Challenging work environments, and they had insufficient training and support at their work sites, and with little to no opportunities for career ladder advancement, as I originally spoke about. And when we see these shortages in the workplace, where we see the impact, who's mostly impacted by these shortages is our most vulnerable populations. And those are our children and adolescents, ethnic and racial and sexual minority groups, individuals with disabilities, individuals with substance use and addiction disorders, our older adults, our elderly, we know that they're suffering, and service members and our veterans, and also folks living in rural areas who find it incredibly difficult to find a mental health provider within miles of their location. And so it's with this in mind that William James College launched the Behavioral Health Service Corps. And the Behavioral Health Service Corps is a paid service learning opportunity for recent college graduates You can think about it as similar to the Peace Corps when these young folks graduate from college, but they're looking for a gap year to do something of meaning, of service, before they pursue either graduate degrees or go out to pursue other interests. And so we've partnered with a number of large behavioral health organizations in the state. We've partnered with large hospitals. For instance, we're partnered with Mass General Brigham, Children's Hospital, Beth Israel Lahey. We're partnered with we're partnered with the Massachusetts Department of Mental Health and a number of other organizations across the state. And those organizations, through an agreement, they've agreed to allow the applicants who apply to this program with 4 hours of release time each Friday to be participating in their academic studies at WJC. So if you recall, I mentioned both time and money was one of the challenges to folks accessing career law opportunities. With the Behavioral Health Service Corps, we've negotiated a competitive entry salary for these folks and also embedded the time for the academic studies right into their employment schedules with agreement from their employers. And so for those 4 hours, we provide them with 9 academic credits in our Master's in Clinical Mental Health Counseling program at the college. Students receive ongoing professional development. They also receive clinical supervision. We provide them with the graduate student mentor to help them get acclimated to the academic environment. And we make sure that they're supported throughout their experience. And one of the goals for the program is we have students commit to a year. So you heard me talk about the 40% turnover in the first year of employment at the agencies that we did the focus groups with. Well, one of the goals of the program is to have students be committed to a year at their agencies. And then in year 2, we provide significant scholarship opportunities for them to pursue their master's in clinical mental health counseling. And so our first year of the pilot program, we've seen that 80% of the students who come in to the program stay in the field, and 70% of those students actually stay at the employment sites that they were originally placed at. And so those early successes have gotten some attention of some philanthropic donors. Mass General Brigham provided us with a significant grant opportunity. I think it was an amount of $3 million to help upscale this pilot program. We're part of a 20-member community-based organization that's doing similar work, but in different capacities. And we're working towards looking at what are some of the challenges that persist in the workforce. What are some of the best practices that we can address through looking at this pilot, and being at the Hello School, being at Brandeis and pursuing my PhD at the Hello School. This is what I'm primarily focused on. We want to look at if there are additional stresses in the workforce that's impeding the workforce from growing. What are challenges the present day workforce are continuing to face? And with the consortium of partners that's partnered with this initiative, what are the best practices that we can learn to collectively try to address this workforce crisis that we're having. The crisis is too big for one organization, for one institution to address alone, and so we definitely lean on our consortium of partners to bring their best ideas and best practices to the table while we do this work. And so with that, I'll stop there and turn it back over to Shirley, please.
Thank you so much, Mark. You've touched on some other issues that we've raised today. There's a whole host of things that we could talk about for hours, but one is, even if we do have good policies about paying for mental health services and supporting services, we don't have people in the workplace to be able to provide those services. So as state policymakers, there are great opportunities to enhance workforce, the mental health workforce through educational programs in its own state education institutions, and also with the kind of work that you're doing in partnership. So that raises some really, really important issues for our state policymakers to give some time to, and we can talk about that a little bit more in the chat. You also bring to mind the fact that our healthcare workers, as workers, employers of healthcare workers have additional amount of challenge in terms of the culture in the workplace and dealing with the mental health needs of their workforce, whether they be mental health workers or first line providers. I was at Downstate yesterday, and the head of security at Downstate is a great guy, and I have stopped to chat with him. He's exhausted. He hasn't had a vacation since the pandemic started, and to lose him to retirement or whatever would be a tragedy. An incredible man who did give so much to the university, and so there's a lot of workers that we often don't think about who really need the kind of supports that we're talking about here. So thank you so much. As we look about these efforts to destigmatize mental health and concerns in the workplace, one of the things, and this has been alluded to in a couple of different ways, is to think about the unique challenges with communities of color. And as I talk with our next two speakers, one of the issues that they raised was it's really more than just color. And I'll let them talk about the cultural issues that they face as frontline workers, mental health providers. Let me introduce to you Dr. Carlene Lawrence and Ms. Clivia Torres, who are both at the Brooklyn Initiative to Develop Geriatrics Education at the State University of New York, which is located at Downstate. Carlene is a nurse practitioner and clinical coordinator and co-director of the interprofessional team. And Ms. Torres, Clivia, is a licensed social worker and care manager for the initiative. And what we thought they would provide you with is some real live experiences about the workers and the families of workers that they deal with on a daily basis. Go ahead, Carlene and Clivia.
Next slide, please. Hi. Hi, good afternoon. I'm Clivia Torres, and thank you for the introduction, Dr. Gerard. So, and I'm going to just introduce my colleague.
Hi, thank you for inviting us again, Shirley, and thank you for inviting us to this presentation. So our grant, we're on a grant, one of the two grants on our service. One is a HRSA grant. It's actually to educate the next generation of healthcare providers to be age-friendly and dementia-friendly. We actually work in the geriatric psychiatry service. And Clivia will introduce herself. She's on two grants, not just one, but two.
Hi, good afternoon. So I actually do work on two grants. One is the Center of Excellence for Alzheimer's Disease, where we actually do testing for older adults to determine whether they have dementia, Alzheimer's, frontotemporal and things like that. But then we also see people that have bipolar behavior, they have bipolar schizophrenia. So we address those. And then I'm also the social worker on the Bridge program, which is like with Dr. Lawrence and with Dr. Gerard. And there I basically just bring like the social work component to the team, like some of the things that we as social workers address with families and things like that. So next slide, please. Neither Dr. Lawrence nor I have any conflict of interest. Next slide. So the learning objectives, hopefully for after this presentation, is for us to recognize that people of color struggle with mental health issues differently than the rest of the population. And that happens because in certain cultures, people were more receptive to seek mental health services. They're more open to the idea of speaking with someone, especially with psychotherapy. We also recognize, or would like to recognize, that people of color are faced with more challenges to obtain the mental assistance that they need or the services. And we're going to talk in a few minutes about the barriers that they encounter, because it's not only like like the financial component, but it's also the sometimes the stigma that's associated with it, or the lack of support that they get from their family members. People of color also face mental health challenges from family, friends, and even from employers. Sometimes they become very concerned. If I disclose that I'm getting mental health services, is that going to impact my relationship on a personal note? Is that going to impact my performance at work and things like that? And then the recognition of mental health issues that are viewed differently, like I said earlier, based on culture and race. Next slide, please. And communities of color basically includes people that are African American. These are just some of them. This is not all of them. People from the Caribbean, people that are Asian, First Nation, Hawaiian, Indigenous, Australians, Latinos, Latinx, Hispanics, the LGBTQ, people from the Middle East, Native American, Native Alaskans, North Africans, Pacific Islanders, and Slavic and West Indies. And we have to be conscious of the fact that in different cultures, people deal with mental illness totally different. Okay, next slide, please. You want to do this, Connie, or do you want me to do it?
So mental illness, so these are some of the statistics I found online. So nearly 1 in 5 adults in the United States live with a mental illness. And these are numbers from 2020. I couldn't find any updated, so this is the latest numbers that were there. Mental illness includes many different conditions at varying degree of severity, ranging from mild to moderate to severe. And as I mentioned before, Clive and I work on geriatric psychiatry, and we actually do see all of the different levels of mental illnesses, from just mild cognitive impairment, which has been made worse, as I mentioned before, by the COVID pandemic. 2 broad categories can be used to describe these conditions: any mental illness, or AMI, and serious mental illness, which is the acronym is SMI. So AMI encompasses all recognized mental illness, so bipolar, schizophrenia, what we on our unit call psychoses. And SMI is similar, but more severe subset of AMI. Next slide, please. So mental illness includes our emotional, this is just for all persons, not just for some persons that have issues, our emotional, psychological, and social well-being, and affects how we think, feel, and act. It helps determine how we handle stress related to others and make choices. And persons in communities of color face other kinds of stress, not just from stress related to employment, which that is also part of it, but stress from being immigrants, stress from being viewed differently by other populations, by other individuals. Mental health is important at every stage of life, from childhood through adolescence into adulthood. And now we, our grant and our service, we are addressing mental health in the older adult population. Over the course of one's life, if mental health problems are experienced, an individual's thinking, mood, and behavior could be affected. And for the population that we're covering, communities of color, people of communities of color, it actually does affect their well-being and their even their employment and finances. Many factors contribute to mental health problems, including behavioral factors such as heredity or brain chemistry. Additionally, life experiences such as trauma, abuse, and family history of mental illness also are problems that also contribute and cause mental issues in the offsprings and in the other relatives. Next slide, please.
Okay. You want me to do that one, Connie?
Sure, go ahead.
Okay, so with in reference to the communities of color, some of the risk factors that they face with, basically it's the cultural beliefs. And we have to be mindful that in different cultures, especially like among the Hispanics in the Caribbean, they do not necessarily recognize the need for mental health therapy, or even the fact that, there is a problem with mental health. Okay, there's also a stigma that's associated with it. Okay, if a person does have mental illness, it stays within the family. They do not, try to get help from other providers or from other doctors. And sometimes they don't even tell the doctor that they're struggling with mental illness. It's taboo to even talk about it. It's taboo to even get help for it. And in certain cultures, like if you do try to get help, your family will almost disown you. Like they will not validate or support you to try to get the help. Okay, and then sometimes like children that are undiagnosed and are untreated, children that have learning disabilities that are not given the services when they need, that can lead to mental health problems for children and or for adults eventually. The ignorance sometimes of the family members, or it's just like not getting the appropriate help for the child. Poverty when parents get divorced. Sometimes people, young kids or even adults struggle with like self-esteem issues, body image issues. Sometimes when their primary language is not English, they do not have the ability to, find a therapist that does speak their native language. The healthcare illiteracy and the ignorance. Okay, we all recognize, and it's been pointed out before that COVID-19 has definitely increased the number of people that are struggling with mental health, the social isolation for people. And living in a disadvantaged neighborhood sometimes does create a problem for people to do seek mental health services. Being an immigrant, undocumented, uninsured, or underserved does definitely pose a problem for the person trying to get the services. Also, we have to recognize that there is definitely a decreased number of mental health professionals, okay? And that is a problem for people seeking help. Families and friends, sometimes they don't accept the fact that the person has mental illness. Sometimes they don't want the person to seek the therapy or the treatment that they definitely need. There's also unsuccessful assimilation into the first world country, okay, or the developed countries once they immigrate to the United States. So acculturation and assimilation is greatly affected by this. Also the lack of trust, like the Western medicine and healthcare versus, the healthcare that some cultures practice and some people from certain cultures practice. And, the biggest challenge is also the fear of deportation and the biased perception of immigrants. Next slide, please. So the barriers for pursuing mental health care is the cost, okay, of even having insurance. It's also the low perceived need. Do I really need the help? Do I not need the help? And if I do need it, is my family going to be supportive of me and things like that? Also the prejudice and the discrimination that they sometimes feel, because they definitely do feel that, there's a stigma associated with them seeking the help, especially when their friends and family try to find out, or even their employers. Sometimes they are concerned about, if I'm working and my employer finds out that I'm seeking help, is that going to jeopardize my job? Sometimes people have certain jobs and they don't have the good education, so they're really concerned about losing their jobs. There's also inadequate transportation, the inconvenience, like I said earlier, they don't know how to access the services, and the lack of professionals. And also, they don't think that the services are actually going to work for them. A lot of people don't believe in mental health in certain cultures. Next slide, please. And I know we're running short on time, okay? So this is just a slide that Dr. Lawrence and I actually found, and we just think it's like very representative of different people of color and the need for like mental health services. Next slide, please. Oh, that was it then, basically. Oh,
Okay.
Dr.
So
Lawrence?
just a summary. So understanding how mental health affects communities of color, hopefully just from looking online to get resources, there's not a lot of resources. There's actually a lot of room for research studies on persons of color and how mental health affects them. One of the things that Clive mentioned is that it's considered a taboo to discuss or talk about mental health in certain communities. I'm from the West Indies, and they would rather think of themselves as being enchanted, like being possessed, instead of thinking of themselves as having a mental health condition. So healthcare is an opportunity for us as healthcare providers and persons in healthcare and persons making political policy to be attentive to the changing socioeconomic needs of persons and implement treatments and recognition and education for persons of color, to know that some do not actually know that there's assistance for them, so that they'll be able to freely go and access care and access treatment and improve their lives. Thank you very much.
All right, thank you, Carlene and Clivia, for sharing your perspectives. These are really helpful, and helpful for both employers, policymakers, as well as providers, because it makes the issue of what kind of interventions, what kind of policies are going to be in the workplace, or that state governments wish to put in place, not quite as simple as we might like. And that, I think, even though physical health is complicated because of all of these issues that Certainly in mental health, there's even a greater concern about all of this. So thank you very, very much for sharing that sort of on the ground perspective and bringing things down to the level of the people that we all care about as employers, as policymakers, and as providers. Our final formal presentation today, as Sean told you earlier, we hope to have been joined by New York State Assemblywoman Aileen Gunther, who chairs the Committee on Mental Health, as well as the Subcommittee on Women's Health, and representing District 100 of the New York-Pennsylvania border. She has introduced a bill recently that will be of interest to many of us, and particularly to state policymakers. But unfortunately, she was called away on other business. But we're delighted that Thomas Gatto has agreed to fill us in. And Tom, what can you tell us about this bill?
Good afternoon, thank you. So I'm Thomas Gatto. I'm the Legislative Director for New York State Assemblywoman Aileen Gunther. I want to thank you for this opportunity to speak on behalf of the Assemblywoman regarding her legislation to require employers to post notices for mental health resources. This is a bill we worked closely on with the Mental Health Association in New York State. From the day Aileen became chair of the Assembly Mental Health Committee, she emphasized how important it was to her to listen to the advocates who are in the field. Aileen is a registered nurse who spent years caring for individuals with mental illness. So one of her biggest priorities is breaking down the barriers to treatment. And what we've heard time and time again is that stigma is a huge impediment to people getting services. The Assemblywoman has passed legislation creating a mental illness anti-stigma fund. So when people register at the DMV for a mental health awareness license plate, or they decide they want to give money to the fund when filling out their taxes, all that money goes right back into our communities. Our new legislation is a natural progression from those efforts. I don't know if we have any fans of the show Severance, but our workplaces don't exist in a silo. Our thoughts and anxieties and worries and concerns and family issues, they don't stop when you walk into work. And that's why we felt so strongly that employers should be given the resources they need to make them available to their employees. Obviously, coming out of a pandemic, we realized that businesses are struggling. The posting of resources in the workplace would be required, but the strategies and programs that will be developed by the Department of Labor and Office of Mental Health will be optional for employers. But we're seeing a seismic shift in the way we talk about mental health. We believe this is something that employees are going to want to see their employers be cognizant of. Employees are demanding their employers make accommodations for things like work from home, more vacation time, and flexible schedules. All these things have a huge effect on a person's mental health. So implementing some of these programs that will be developed will be a way to demonstrate that an employer takes seriously the mental health of their employees. The bill is currently in our Ways and Means Committee in the Assembly, and we're pushing for passage in the last 2 weeks of our legislative session here in New York. Again, I want to thank everyone for having me here to speak on behalf of Assemblywoman Gunther. And if anyone has any other ideas for legislation, just know our door is always open, and you should feel free to get in touch with our office anytime. Thank you.
Thank you so much, Tom. That's really fascinating. Ideas about things that are relatively simple that policymakers can do and employers can do without the policy as even being in place. That's something that I hadn't actually thought about very much. And I think from our presentations so far today, we've got a number of issues in relation to what policymakers can do relative to telehealth, relative to workforce development, relative to parity with mental health and health benefits. And I know there are some pieces of legislation that are enhancing that around the state. So we also haven't talked much about the issue of workforce members who have family members who have mental health issues who may need support. And how do we as employers help to support them? And what are the kinds of policies that can be in place to do that? So let's, we have a good 20 minutes, I think, left for discussion. So let's see what we've accumulated in the chat. I've been monitoring it. There's a number of interesting issues there. Sean, can you share with us some of the?
Sure. So we had one question, and I believe this was for Mark. Somebody was asking about the percentage of adults that have a mental health diagnosis. Mark, if you're still with us, just a clarification on what that percentage is. If you want to unmute there.
Sorry about that. Yeah, so there's 18.1%, which equates to 43.6 million Americans currently that has a diagnosable mental health illness.
Great. Let's see. So we had a comment here about it says, does anyone want to address the difference between perceived workforce shortage and a statistic that this person learned last night, that there are actually 750,000 mental health workers in the United States?
So
Go ahead.
I can't speak to the specific number that the senator cited in the chat, but if I was gonna dig into that question, the two places I would look would be HRSA, which has the behavioral health workforce shortage designations, and they do really good mapping. And the same is George Washington University's Mulligan Institute, I believe it is, has interactive where they track where we have shortages in mental health care providers. I think they break it down by all of the subspecialties. I do think, and others can speak to this as well, but when we talk about the shortage, we're also talking about the subspecialties of the provider. There are lots of people delivering care. We need lots of people delivering care.
Mark, did you want to weigh in on that?
Yeah. Am I unmuted?
No, you're good. Go ahead.
We can hear you.
Okay, I was just going to add that the numbers that the person is speaking to, that represents what's currently in the workforce, but there's still a huge demand. So, for instance, for school counselors, the current supply is around 2.5 million counselors in the workforce, but we're still short 321,000 counselors. And when we look at clinical mental health and clinical counseling and school psychologists, we have about 1,888 folks in the workforce, but there's a projected shortage of 246,000 folks in workforce. For mental health counselors and social workers, we're right around 109,000 in the workforce, but there's a projected shortage of 157,000. And it goes on for mental health counselors, social workers, psychologists, marriage and family counselors, so on and so forth. So although we do have people in the workforce, but the projected shortage far outweighs the number of folks that's currently in the workforce.
Yeah, the employee assistance programs too, I know are always looking for staff to work there. I have a friend who works for a federal agency, and there's a real shortage of folks available to provide the counseling services. And then the number of psychiatrists available to work with those who provide the talk counseling and the support counseling is not adequate, as we know from our work. We know that's why I think HRSA has invested money. It's also interesting to note that a number of states have made significant investments using some of the new federal monies in specifically to the mental health workforce. and developing those through different kinds of programs. I think, Mark, the one example that you gave is an example of one thing that was done with grant money, is a way to increase the number of social workers in the pipeline to get people engaged.
And Shirley, another way of looking at it is here in Massachusetts, there for every 180 residents, there's one mental health providers. And when I started my talk, I said we was the best resource. So that makes us like that's as good as it's going to get. On the other side of that spectrum is Alabama. There's for every 1,000 and for every 1,100 residents, there's one mental health provider to service that population. So it kind of gives you the vast differences in the access of care when you look at different states across the country.
I also wanted to say that I was a school social worker actually for many years. And like the ratio of students to one provider, one social worker, it was like 100 to 1. And, you know, especially I worked with the special ed population, the students that had special needs. And there were many times that I was pressured into, you know, decertifying the kid for the counseling part and send them out into the community because we had other children within the school that needed the same service. So there definitely is a lack of providers, mental health providers for schools, for, you know, EAP programs. You know, even in the community, I can tell you, sometimes I refer patients that are in my community in Brooklyn, and they basically have to wait for months because some of the providers do not accept Medicaid. They may not accept the insurance that the person has. And even within like some of the managed long-term cares, there is a lack of providers.
I think another question we had was for Matt.
And just sorry. And just to add to that, even we're at SUNY Downstate in Brooklyn. We currently have one psychotherapist, and the wait for her is months. So we're actually referring patients back to their health insurance.
Right.
So to find a therapist in their network, which would be faster, instead of waiting for her, because she's booked up, I think, all the way till October right now.
Right.
So it depends. I think it depends on the area where there may be shortages, or it depends on the community. And again, as Clivia said, it depends on if you're insured, if you're underinsured, if you don't have insurance, that's also another issue.
If you're doing private pay, of course, you can see a therapist. But if you have to wait because you have, you know, Medicaid, or you're just waiting for insurance, then it's a real long wait for you.
I think another question that we had was for Matthew, and it was something about the company size that you mentioned in the survey data. Has anyone considered whether the community environment differences between a small employer and a large employer has something to do with mental health, is what this person is asking. In other words, connections help, they say.
Yeah, I'm sure. I'm sure someone's done work on it. We haven't looked at it. I think that our statistics are driven by how the large firms are just much more engaged in running their health benefits. They have a much closer pulse on what's going on. But I'm absolutely positive there's different sorts of people work at small firms versus large firms, and being different sorts of industries, and I'm sure all those differences matter, and that we need to tailor mental health, workplace mental health solutions to the workforce population.
Great. A question for Carlene and Clivia. You know, on the communities of color and everything. One thing that we see frequently in sort of policy and legislation is this idea of culturally competent care. Is that something that you know, can be brought to bear on some of the issues that you see in these different communities?
Let me go first.
No, you can answer first.
So as I said, we're on a HRSA grant, and our grant is to educate the next generation of healthcare providers, because the current generation of healthcare providers, we've come to realize, have biases, whether implicit or not, that is impacting the care of, as I said, our population usually is older adults. So as far as competent care, we're actually hoping to educate these students to provide that going forward. But right now there is a disparity, especially in our community. Our community is a
You
very
kind of
diverse
froze
community.
up there for a bit, Carlene.
I'm sorry. Oh, I froze. Sorry. Can you hear me now?
Yes.
Okay, so in our community, we're a very diverse community. I think we have representation of every nation in Brooklyn, and they come through SUNY downstate or Kings County, our counterpart across the street. So there is inequities of care in our community, definitely.
But I think, and Mark may want to speak to this too, one of the things that I think a number of initiatives are trying to do at the state and private level is to increase the diversity of the workforce itself.
Oh, absolutely.
And I think that's one of the ways we can contribute to that. And there are programs at both in private universities and states, and Mark may know more about that as well.
Yeah, Shirley, and what I'll say to that is when we look at it, 90% of the behavioral health field or the psychology field, 90% of the psychology field is white. And that is in no way representative of the larger population. And so when we look at the behavioral health workforce, it's imperative that we recruit a diverse and culturally competent behavioral health workforce that will be more representative of the communities that those folks will be serving. Because what we find is that when folks from the community, I think other presenters talked about the stigma of mental health and not wanting to pursue counseling services, when they do finally go into counseling and they're sitting across with someone who does not look like them, who's not aware of their culture, who doesn't know the community that they come from, it makes it extremely difficult for that person to come back for that second and third visit because their counselors are not representative of that community.
It's also very difficult sometimes for a person of color to engage with a therapist, let's say, that is different from their own culture. But like what you just said, Mark, they don't understand, some of their behaviors. They don't understand some of their beliefs. And, we also have to consider sometimes that, within mental illness and mental health, religion is also very important, especially to communities of color. And sometimes therapists cannot make that connection. Like as a Latina woman, I'm able to talk to the patients that come to our clinic, and I'm able to ask that question because they identify with me. But I also know, and I worked in the Bronx, I worked with adults, I've had a lot of experience in my field, but you have to be sensitive to the fact that religion plays a very important role in the people of color in their lives.
Sean, this is Bobby. Would you like me to share some examples of state policies that address the issues that you're have been discussing the last couple of minutes?
Absolutely, and I think Elise also inserted a couple into the chat, but certainly go ahead, Bobby.
Okay, Elise, you want to share the two first that you've identified in the chat? And then
yeah, absolutely. One is from Nevada, and that requires certain mental health professionals to complete continuing education related to cultural competency. And so it doesn't necessarily address that point of fit in terms of, I think as Mark had said, working with somebody who looks like you and comes from your same background, but certainly just increasing skills to serve a wider range of individuals. And then the second one is from Oregon. There's a bill that requires the Oregon Health Authority to expand funding, develop programs, and provide incentives to improve access to culturally responsive behavioral health services. And that's a pretty ongoing effort. So I can include links to the specific bills as well.
In addition to those two bills, Colorado in 2021 passed HB 1232 that dealt specifically with the culturally responsive healthcare provider network to make sure that the network itself was. Illinois HB 158 in 2021 requires implicit bias training in continuing education. Washington, SB 228, also enacted in 2021, requires training on health equity, including tools for eliminating structural racism in the healthcare system. So that's a couple of examples. California has the California Future Health Workforce Commission, and its task includes making sure that that mental health professionals reflect the diversity of the population they serve.
In Connecticut, and I know some other states, Connecticut has declared racism a public health problem. And I know some other states have done some similar actions, which will obviously affect the mental health workforce and affect the mental health as well, all of our mental health.
Sorry, I just wanted to jump in on our, the Assemblywoman passed legislation for the implementation of the state bill for 988. And part of that was culturally competent care training at the call centers for people who call into 988. So just wanted to get that out there.
Great. Are there other?
Tom, there was a question too for you that I had, and it's sort of in terms of the bill that the Assemblywoman was working on. Have you seen any limitations in terms of what state policymakers can do to encourage employers and assist employees, but not overstep their bounds in terms of providing guidance or voluntary standards for the workplace?
In terms of limitations, no, I think that's why we kind of left it up to the experts in the bill that we have. So because it's in labor law, the commissioner of the Department of Labor would be the one charged with putting out the recommendations and the guidance. But we included that they must do it in consultation with the Office of Mental Health. And the Office of Mental Health obviously employs many people who are on the ground and providing care. And like I said, we wanted to leave it up to them to determine what they feel would be best and how employers can best reach their employees. We do reference a few specifications in the bill that employers can do, like establishing a website. And like I said, part of it is that there's a requirement that employers have to post notice about where they can access resources. And I think there's information on the 988 hotline and other references too.
Sean, this is Bobby again. There's a very interesting bill from Indiana that was enacted in 2018, which permits but does not require employees to offer employees who fail drug screening an opportunity to retain their employment if they participate in drug education and addiction treatment programs. And it also has a very interesting provision which protects employers who participate in this program from being sued for that employee doing something that could create a problem. So there's an incentive for the employers to participate in this program. So employers would not be liable for civil action alleging negligence in hiring of such an individual or retaining that person.
That's very interesting. Raises points about the many different types of legislation that are part of addressing issues of mental health. We haven't touched on the judicial system and some of the issues there that need to be addressed. States have, and one of the things that helps with the workforce are these interstate compacts for workers. But one of the things that is deterring Connecticut, for example, from getting involved in the interstate compact is the fact that Connecticut has, for its physicians and nurses, and I think some other health providers, a clause that we pay a certain amount of money on our licenses that goes into a fund that establishes rehabilitation for substance abuse and mental health problems for workers, so that they can return to the work environment and practice safely. And so not every state has that. So Connecticut's sort of, do we have to pay for that? How are we going to do it? So that adds another twist, a mental health twist to issues that we don't often think about, that it does get involved. So we're nearing the end of our time. Well, I want to thank you all. This has been a lot of fun and very stimulating for me. And it certainly raises a lot of issues. And you've all had wonderful questions, and I appreciate, we're all grateful for your participation, and efforts to address the mental health needs of workers are important to all of us, whatever role we're playing, and certainly important to society. So we'll hope that you'll continue to keep an eye on these awareness. This is Mental Health Awareness Month, so we're all sort of on top of it, but I don't think we're going to be able to let this go. So we look forward to hearing more from you, and for you to hear more of us about what states are doing to address these issues. But in the meantime, please let us know of your concerns and issues, and if there's anything that we might do to work together to address some of these concerns. A special thank you to my colleagues at CSG and my colleagues at CSG East for putting this program together. It really has been enlightening for me. But check out the resources. There are a number of available, some that were put in the chat today. But SEED, you can go to the SEED website. It's capital SEED.csg.org. And if you have a need for any technical assistance on policy issues or want additional information, please don't hesitate to reach out to CSG or CSGs or both of us. And we do work together on many of these issues. So we appreciate your joining us today. It's been a lively conversation, and we look forward to hearing from you all in the future. And Jennifer's got a parting word here. Please look into schools in minority communities. Yes, absolutely. And we are one of those at SUNY Downstate, and we're grateful for your support and for that comment. So thank you, everyone, and we'll be in touch with you, and please don't hesitate to call us. And thanks to the presenters. Goodbye.
Bye.